want to talk about arrhythmias. For both PTs and PTAs, major things are really the QRS complex, because that's the contraction of the ventricles, and the ST segment. The ST segment has to do with a lot of things, including myocardial ischemia, which if we exercise somebody, they do get a little ischemic. So it's important not to get them too ischemic. And you start seeing things like MIs and things like that also showing up in the ST segment, also myocardial damage. So those are major things that we need to look at. But there's some other things in here as well. Maybe probably more on the PT exam than on the PTA. Normal wave pattern, you got a P wave going to a Q. The QRS is what is called the complex, and that's the depolarization of the ventricles. The right and left should depolarize at the same time. That gives you one spike. Sometimes when the right goes first, the left goes second, you'll see two spikes instead of one. So you'll see two R waves instead of one R wave. You'll see it go up, come down a little bit, then go back up again, then come back down again. The big thing there is the width of the Q to the S, because that should be less than 2 boxes in there to be fairly normal. Otherwise, if it's more than that, that wave of depolarization is taking a long time to get through. The longer time it takes to get through, the more accommodation you have, which means a big decrease in the force of contraction, which could present with symptoms like heart failure in your patient. There should be, usually depolarization starts at the SA node, which is the apex of the P wave. Then goes the AV node, somewhat fires off about the Q wave. The sinoatrial node, which is in the upper portion of the right atria, fires somewhere around 70 to 80 times a minute. It's just an area of the myocardium that's more irritable. That's what the nodes are. If that doesn't fire at all, you won't see a P wave. But the AV node is the second most irritable spot in the heart. And it's really at the septum, right between the ventricles and the atria and between the right and left side. Right somewhere in that septum area, heart rates coming from that are usually a little bit slower. Not necessarily bradycardic, but they're definitely slower, like 70, 60, maybe down to 50, really depending on how stressed the patient is. Sometimes if they're on a pacemaker, you actually feed in the pacemaker through the subclavian vein, the right subclavian, and it's going to hit bottom right about where the AV node is. So the electrode from the pacemaker is going to be very similar to the AV node, and it sort of paces like the AV node. Most of the time, pacemakers are set around 70. So if the heart rate is above 70, the pacemaker shuts off and saves its battery. When the heart drops below 70, it'll start stimulating the heart. Most patients, that happens during the night when they're sleeping, because that's when your heart rate's the lowest. And sometimes it'll get too low at that point, and you need a pacemaker in there to try to pump it up a little bit. But that ST segment is the recovery of the heart, and this is the repolarization of the ventricles there. That's really important to us. Like if you overexercise somebody, you really don't see it until like the next day when they get really stiff and sore, if you've been too intense with your exercise. With the heart, you'll probably see it fairly quickly, but you can see if a patient tolerated the type of treatment you were doing with them. There are 12 leads to a full EKG or ECG exam. Now, ECG and EKG mean the same thing. We use the term EKG probably to differentiate it more from EEG, which is brain waves, because ECG and EEG look very similar. So it's easy to confuse the two. So that's why some people use the term EKG instead. But electrocardiogram probably should be C instead of K. Lead 1 is pretty much if they give you one strip in a textbook or something, it's often lead 1. But lead 1, 2, and 3 are your typical limb leads. You do need to know the placement of them, because that has been asked on the exam. Lead 1 and lead 2 normally look fairly similar, but there's slight differences in amplitudes of different waves, and cardiologists get all into that, trying to calculate that amplitude in the different leads. There's augmented leads, AVR, AVL, AVF, which are halfway in between the limb leads or the axial leads. So they're halfway in between there. That gives you a little bit better representation of the heart. And there are formulas you can apply by taking calipers and looking at amplitudes and the different leads. determining how much of the heart is ischemic, how much of the heart is necrotic. Those type of questions can be asked through that by the calculation of something called axis, which you're not going to have to do, but that's what it's used for. The augmented leads are usually built into the machine. They're just done electrically. They're not actually leads that you place on the patient's chest, although you could. The precordial leads, I think I would know where these are, because when you pick up a set of electrodes to put on a patient, it tells you right arm, left arm, and foot for the limb leads. They're labeled that way. That's pretty easy. AVR, AVL, AVF is done by the machine itself, but the precordial leads are actually placed on the patient's chest, and you need to know where to place them. So if you go back to the webinar or the notes for week 2, there's the information there on how to place these. I don't know if there's information here. No. So you may want to know those. V1 reflects the right atrium, which is the SA node. So if I want to see what the SA node is doing, I look at the P waves in V1. I'm recording from that spot, so my QRS deflection is negative in that lead normally. If this would be positive, in other words, the R waves would be flipped up, that would be a problem. It would be actually a fairly serious problem. V2 looks at more of the left atrium. It's to the left of the sternum, up high. V3 is the AV nodal area, so if I want to see what that AV node is doing, I'd probably want to run a precordial V3. Just a little bit closer to that, more over the mitral valve area, is V4. V5 is at the apex of the heart, which shows primarily the left ventricle. And the left ventricle is your largest pumping chamber of the heart. So you really want to know what the left ventricle is doing, because if the left ventricle is doing fine, that's 80% of your pumping capacity right there. So if it's not doing fine, that could be a problem. When I'm exercising a patient on an EKG and I can select which leads to run, I almost always run a V5. Oftentimes I'll run a V1 just because that's what I usually see in the textbook as far as identifying arrhythmias, but V5 tells me how the ventricles are actually doing. And if you notice, I have a little bit sharper peaked R waves here and a little bit better looking at the ST segment as well. V6 is the most posterior lead, and it pretty much goes through the septal area of the heart. Now, the heart is not straight in the chest. It's actually twisted, so the right ventricle or the left ventricle is normally the anterior wall of the heart as far as the heart laying in the chest goes. It's also cocked to the left side, so the apex is going more to the left. That puts the right ventricle being the posterior wall. And the EKG really doesn't look at that posterior wall. Just looks at the septal area, but doesn't really look much behind that. So you can miss a posterior wall infarct fairly easily. But affecting the right ventricle is the pumping up to the lungs, which there's a fair amount of blood pressure pushing the blood up to the lungs anyway. And it's something that you may have a 10% decrease in cardiac function if the whole right ventricle was not functioning at all, which, yeah, you'd see a little bit of impairment as far as the patient getting slightly more shorter breath, easier upon exertion, things like that. But in resting, you probably wouldn't see any deficit at all. Posterior wall infarcts also give pain back between the shoulder blades, not in the chest area or the jaw area or the left arm. It's back between the shoulder blades. And again, being very unusual, it's missed quite often. And because it doesn't show up in the EKG at all, you don't see really any EKG changes with it, you got a problem. The bottom strip you can set. This is set for lead 2, and we just ran lead 2 all the way through. Now, one lead is usually 6 seconds long. And the reason why it's 6 seconds long is you can simply count the R waves, put a 0 behind it, and that gets you the heart rate. Really quick, really easy. So 1, 2, 3, 4, 5, heart rate's 50. And that probably would indicate the SA node is not functioning, and I don't see much of a P wave here. I see a T wave. If you just see one wave between each R, it's got to be a T, because after the ventricles depolarize, they have to repolarize again. The atria don't necessarily have to contract. That's both atria combined is about 10% of cardiac function. And usually it's not completely both of them. Usually you have some contraction going on. Rhythm strip we look at to identify things like couplets, things like bigeminy, where they have two different bigeminy. There's actually two different conduction pathways going through the heart, so you have two different rhythms going on at the same time. That's not good, and when you see that, you shouldn't be exercising somebody. If you start seeing a bunch of couplets, you usually want to stop exercise. Now, you could come back later in the day, look at their EKG, you don't see those artifacts in the EKG, then it would be safe to go ahead and exercise them. I also like to print out a strip if it's abnormal and put it in the patient's chart, because when the cardiologist comes in, they may not be displaying the arrhythmia that I saw when I held them. And the cardiologist needs to know that they need to know why I held the patient. And they maybe can do something about it, medication-wise or surgical intervention. Usually it's medication. So you could run a V5 rhythm strip, you could run a V1 rhythm strip. You usually pick something where it demonstrates the problems that our patient is having. The ST segment, as I said, is probably the most important to PT. And on the NPTE exam for physical therapists, you usually have two strips. Sometimes exams don't have any, but oftentimes there's two for you to interpret. And if there's two, one is about the ST segment. The other one may have to do with P waves, may have to do with bigeminy or couplets or something like that. May have to do with a widening QS, which means it's got a slow conduction through the AV node, bundle of His and the bundle of branches, and you don't have a good force of contraction of the heart. That's something you'd want to know about. Because if they don't have a good force of contraction, they may even be stressed out at rest. They definitely will be stressed out with even minimal amount of exercise. An ST segment, I put in what's called a J point, right where it comes down to the S wave, starts coming up and changes direction. Where it changes direction, that's the J point, where it first changes direction. And that's important in rehabbing somebody with some myocardial deficit, such as damaged myocardial tissue. And it really reflects that. It also reflects ischemia in the heart, too. Now, this isn't on the line, and sometimes they aren't. You can usually move this up and down a little bit and try to put it on a line on the grid paper so you can actually see it. But the J point would be there. And there's something called the slope, which goes from the J point to the apex of the T wave. And normally that should be always upsloping. If it's downsloping, that could indicate an MI. And it's the same thing as saying an inverted T wave, which is more the academic way of approaching it than the clinical way. But both could be in an exam question. So an inverted T wave or a downsloping ST segment, we are saying the same thing, and they're telling you MI. And when you see something like that occur, it's activate the emergency medical system. But if I flip this T wave over, then I go from the J point to the apex of that T wave, I'm now have a downsloping line. Myocardial damage elevates the J point. And not very quantitatively, but more qualitatively, the more elevated it is, the more myocardial damage you have. But it could be edema in the myocardium that would elevate the ST segment. So right after an MI, you usually see it fairly elevated, but 2 to 3 days later it's starting to come down. It won't come all the way back down to the isoelectric line. It'll always remain a little bit elevated because scar tissue will also, that would fill in the damaged myocardium, that usually takes about 4 to 6 weeks, is non-conductive. So it would cause it to be an elevated ST segment as well. Myocardial ischemia is a depressed ST segment. It's going down. So the J point is now below the isoelectric line. And how far it's below somewhat reflects how ischemic they are. With most patients, we can let them go about 1 millimeter or one of the small little boxes. Phase 1 and Phase 2 cardiac rehab, you pretty much want to keep it there because we don't really want to stress the heart muscle that much at that point. You want to get a little function out of them. You want to get them into a limited community ambulation so they can get to outpatient. You want them to be able to exit and enter their house maybe, but not carrying anything, because carrying something almost doubles the amount of intensity of exercise and the MET requirement. But you want to get them into the outpatient front door, basically. They have to be able to walk about 200 feet because that's what the handicap parking is all about. They have to be within 200 feet of the front door or less, and that allows the patient to go to outpatient rehab, which is usually 4 to 6 weeks post myocardial damage. Now, somebody that had a cabbage, but they didn't have a heart attack before the cabbage, often they do. You need to look at their history to determine that. Sometimes they'll have an MI, then 3 to 4 days later they'll do a coronary artery bypass graft on them, or they'll do a balloon angioplasty or endocardectomy, trying to open the coronary arteries up more, but to reperfuse that portion of the heart. And they try to do it as soon as they really physically think they can get away with it. I've had some patients come into the ER room and basically say hello to the people in the ER room and go right to the cath lab. They sort of stop and wave at people on the way to the cath lab. And the faster you can get the heart reperfused, probably the less myocardium that ends up being truly necrotic. Ischemic heart is going to cause your chest pain. Patients with an angina attack usually have a depressed ST segment. Phase 3 cardiac rehab, which is outpatient after the heart muscle is healed, which is 4 to 6 weeks, or you can start pushing it now. If you push it too early, you're going to create more scar tissue and more elevation of the ST segment if you push it too early. So waiting about 4 to 6 weeks is about perfect, and that's what that phase 2 cardiac rehab's about. It's more of a waiting period of time than anything else. You want them to exercise fairly minimally to begin with. Phase 1, to be able to go home, for instance, they have to be able to get out of bed, walk to the bathroom, use the toilet, maybe rest in between times on the toilet before they get up and go back to bed again. They need to be able to sit in a chair for about 20 minutes because that's how long it takes to eat. And you really need to be upright to eat well and digest well. Otherwise you get GERD problems and things like that going on, gastroesophageal reflux disease issues, and possibly aspiration pneumonia from it. So you really want them to be able to sit in a chair for at least 20 minutes. If they have a spouse or a caregiver, if they're untrained, they probably should be a minimal assist level. But if you have family taking care of somebody, you really want the minimal assist. If you have a professional caregiver, like a CNA, for instance, even, or a nurse working with them, then probably a moderate assist. But most patients do not have a CNA in their home, things like that. It's starting to be done a little bit more, but traditionally they would be either transferred to the subacute unit in the hospital to recover a little bit more to get to that minimal assist level so the family can take care of them, spouse usually, but it could be a daughter or son as well. That caregiver really needs to be there about 24/7 with these patients too, or they need to have somebody else, maybe hire somebody else for the hours they're at work or something to be with the patient, who can, if they're trained, maybe can do a moderate assist level, and maybe you can get them back home a little bit faster. If it's an untrained person, you do want the minimal assist level, but that 4 to 6 weeks allows the heart muscle to heal. You don't want to push it right away if the myocardium's damaged. And it could be damaged by surgery too, like going in and putting a valve in the heart. You have to cut through the myocardium at all, you're damaging the myocardium in so doing. And you're going to see some myocardial damage as a result of the surgery. You're also going to probably see a lot of chest pain with somebody who had a cabbage, coronary artery bypass graft, because they basically saw through the sternum, cracked the chest open. Basically, they saw through the sternum, put rib spreaders in, and just open it up. And they'll probably break a few ribs in so doing. If a patient, particularly geriatric patients, have had CPR done on them, very likely they would have broken a few ribs during the CPR, bruised the sternum, probably not fractured the sternum, but bruised it at least. And you have to have sternal precautions with those patients. And it's more for pain than anything else. Although sometimes if there's too much movement of the sternum and the ribs, they don't like it. That keeps it from healing. So that you don't want them opening the chest up a lot. So you don't want them doing adduction exercises. They could be doing abduction, but not adduction with their upper extremities. When they're coughing, they probably need to hold a pillow or just grab their chest and support it with their arms. So they're holding that cut sternum together. Because if the sternum's moving too much, you end up with a non-union fracture of the sternum sometimes. That's pretty rare, but it does happen. And usually in a patient that's not following sternal precautions that needed to follow sternal precautions. So depressed ST segment indicates myocardial ischemia. With patients, we can phase 1, phase 2, we can let them get a little ischemic, and that gives you a hint you're actually getting to the heart. And like any muscle, when you're training it, it means you're stressing it, and it gets stronger as a result of that. But too much stress can cause problems. So about 1 millimeter of depression of the J point is considered normal for like an inpatient or that phase 2 cardiac rehab, being in the subacute unit or being in home health. Now, home health and the subacute, you usually do not have an EKG to go by. You very easily may have a pulse oximeter, though, and vital signs to monitor the patient. Phase 1, when they're in the ICU or CCU, then you have the telemetry and things like that that you can set and really evaluate the EKG as you're working with the patient. And you should, if you have it available, you should be using it. So the EKG we usually see during phase 1 cardiac rehab only. Elevated ST segment is necrotic myocardium or edematous or scar tissue in the myocardium. It won't come, that J point will not come all the way down to the isoelectric line. And sometimes a patient will go in, see their doctor, they do an EKG. So yeah, it looks like you had a heart attack one time. I don't know when you had the heart attack, but you had one because you got an elevated ST segment. To determine stress on a patient like that, you would actually print out an EKG, or actually in a lot of the telemetry machines, you can bring like a red line up or something, or a blue line up, and set it along all the J points, and they can go 1 millimeter depression from that line, and you can safely exercise somebody with myocardial damage because they're elevated to begin with, but you don't want to take them down 1 millimeter below the isoelectric line, because then you're really overdoing it with them. It could be like 2 to 3 millimeters if you did that. You want to use that new line from the connection of the J points to give you that determinant factor. Depressed ST, which is myocardial ischemia, identify the J point, but you can see it's a little bit lower than the isoelectric line is if you look really carefully. This rhythm strip here in V3 and V1 is showing atrial fib. See all the funky little lines here? That's what ventricular fibrillation looks like. And it's sort of irregular. Not all the P waves look the same. And I have a fairly high peaked T wave in like V3. So it's taking a little bit more to recover. Because you've lost about maybe 5–10% of the pumping capacity of the heart. As far as your exercise program or things you might want to do, I wouldn't care if they have atrial fib or not, because it's not going to change what I'm doing as a physical therapist with them. And actually, if they have atrial fib, the problem with atrial fib is the blood just sits in the atrium. It doesn't get all pumped in the ventricle. And if it just sits there, you can start forming clots and thrombuses. Thrombuses being formed in the right atria, those thrombuses would go into the right ventricle and then being pumped up to the lungs, possibly causing a pulmonary embolus. If it's on the left side, more common, it's going to be coming in through the mitral valve down into the left ventricle and being pumped out to the body. And the straight line up the aorta and the straight line up actually goes into the internal carotid and then goes into the medial cerebral artery. So there's a high correlation with atrial fib of the left side, or affecting the left side of the heart, causing strokes, particularly the ischemic stroke, because usually they have a little bit of atherosclerotic disease, or they've had chronic high blood pressure where the arteries are starting to narrow because the muscular wall is hypertrophied, which narrows the lumen, and then the thrombus just adds a final plug, and that causes your stroke. Generally, if you exercise somebody, you're going to move the blood through the heart better. You're going to move more blood through the heart. That prevents them from forming thrombuses. So there's really no reason not to exercise these patients with atrial fib. Atrial flutter is, instead of this sort of very different looking P waves, and these are all little P waves because different areas of the atria are firing off, atrial flutter is coming from one area. There's one particular spot that's trying to do its own rhythm. And you get sort of like a sawtooth looking thing. And all of them, they're not quite as close together, packed as close together as these. And it's definitely more of a sawtooth appearance. And they really sort of look all the same because they're coming from the same area. The atopic foci, or that abnormal area, is the same. Elevated ST segment, myocardial damage. And usually right after an MI, it's going to be more elevated. Later, it's going to be less elevated. Other things we could see is pericarditis, which is an ST elevation in AVR. Usually this is one of the augmented leads. Pulmonary embolism, sometimes you see in V1 and AVR, both with ST segment elevation, just in those leads. Myocardial damage would be really in all leads, so you can differentiate that way. As far as the PT is concerned, I don't need to differentiate that. I just need to know I probably don't work with the patient. And they have a pulmonary embolism, they'll have chest pain, and usually a big, huge cough with it, bronchial spasms. MI would not have bronchial spasms. They may have shortness of breath, those type of things, but they don't have bronchial spasms. Don't abbreviate shortness of breath, because if the patient looks at it and uses the initials, they're not good. They're thinking you're calling them something that's not too nice. Hypotassium level or hyperkalemia will do that. Now, hyperkalemia is also associated with a lot of muscular weakness throughout the body and confusion neurologically as well. And you can sort of see those type of things there. Abnormal heart rhythms that are really common, premature ventricular contractions, probably the most common we see. They can be multifocal, which means they're coming from different areas of the myocardium. And when the myocardium gets ischemic, that ischemia can actually cause a depolarization of an area that is ischemic in the myocardium. So you start a new QRS or a new complex related to that atopic foci. In other words, the little portion of the myocardium that's very ischemic. You can see couplets, triplets, etc. If you see those, hold exercise. It wouldn't alert the emergency medical system, but I would hold the exercise. I could describe it in the patient's chart so the doctors could see it, but a strip probably says a lot more than your description ever could. Bigeminy, there's two rhythms going on. One's usually normal, one is usually abnormal. Trigeminy, there are three rhythms. One of the three is normal, the other two are abnormal. Conduction pathways through the heart, because they're starting from a different area of the heart, and they're starting from the same area, and they're repeating it. That's sort of important, because once you have a problem starting from one area, that means there's an area of the myocardium, small area, that's probably not getting enough blood supply to it, and you're getting a lot of decreased coronary artery supply to that one particular area. If you would exercise somebody with a bigeminy or a trigeminy, chances are you may take it from just being ischemic and causing the extra conduction thing to going necrotic on you and really causing an MI. So I would hold these patients, but then I'd come back and look at them maybe a couple hours later and see if that's gone or not. And sometimes these are very transient. So they're there one moment, gone the next. Couplets and triplets the same way. But if they look the same, they're coming, and they're both at, like there's two abnormal beats, that's a couplet. It's the same area of the myocardium, which is usually getting fairly ischemic, and if you stress them, could go necrotic on you, which is an MI. Atrial fib, atrial flutter, I think I covered that already. As far as seeing these, I would look at their medical record and see if they're being treated for atrial fib or atrial flutter first, if it's known. If it's not known, I want the doctors to know it. So I'd either describe it by writing a note in the chart that the doctor would see, or I'd put a strip in the chart, and the strip is always better. But I wouldn't hold exercise in either of these cases. Maybe a little bit more with the flutter thing than I would with the fib. Because flutter, one little area of the atria, it could go necrotic on you if you push them too much. But usually that doesn't really have a significant impairment. Sinus tachycardia, anything that says sinus means there's a P wave for every QRS. So between each QRS complex, there's two bumps. One is going to be the T wave, the other one's going to be the P wave. You have to have the repolarization phase, which is a T. You don't necessarily have to have the P, and they tend to be relatively fast. And adults tend to have more of these fast rhythm problems. Infants, on the other hand, more have a bradycardic rhythm when they get in trouble, and their heart rate gets really slow on you. In adults, somebody with extremely high blood sugars are probably already in a diabetic coma, and you may see something like that change in there. The heart gets really, really slow, and if it gets slow enough, it's not perfusing the body, the brain, or other major organs of the body well enough, and it could cause death of the patient that way. And that's really how somebody with diabetes may die if they're not treated. and the blood sugar level is not brought down, and the pH isn't raised enough. They're that acidotic. But usually we see fast rhythms in there. And again, you simply count the R waves in each lead. 1, 2, 3, 5. There's probably one here, 6. That would give a heart rate of about 60. Usually it's faster than that. True tachycardia, some reference sources will say over about 110 resting. Other books, going to a little bit older sources, use 120 as the make or break for true tachycardia or not. But if I get anybody with a resting heart rate over 100, I start getting worried. I start being a little bit more cautious with them. I would increase intensity at a slower pace. I wouldn't increase intensity as much. And I try to keep the intensity down with a patient like that, of what I'm doing with them. I actually like the one EKG I had before with it shows a little up and down lines, because that's really what atrial fib looks like. Now, 60 cycle interference from the electrical lines going into the EKG machine can cause that. If there's a suction machine with an electric motor very close to the EKG machine, it may pick up that 60 cycle interference from that. For less than tube lights, particularly when you first turn them on, the starters are active, it'll cause a 60 cycle interference as well. Sometimes just shutting the motors down in the area, shutting the lights off in the area, would see if they really have atrial fib or 60 cycle interference. If there's a diathermy going on, either in the room next to them, maybe even a room and a half or 2 rooms over, or the room above them or the room below them, the electromagnetic energy from the diathermy can also give artifacts that look like atrial fib as well. They can cause like a 60 cycle interference as well, and they're fairly easily. That's why diathermies are not liked in the hospital very much, because it does throw off a fairly large electromagnetic spectrum, sort of like an MRI does. But we're looking at the P waves, and there's a whole bunch of little P waves here. I don't really like this example that well. You also see sometimes a wandering baseline like this, which is probably more typical of 60 cycle interference than is atrial fib. But you can see that there's probably several little P waves in here. One bigger one, but a bunch of them. There's an inverted T wave here. That would not be too great to see. Well, inverted T wave in B1 would be okay. And it's just one particular portion of the atria that's causing that. And it's one portion. If you re-stress it, it's probably ischemic to begin with. It could go necrotic on you. Now, somewhat, if it goes necrotic, you get rid of it. And one treatment for atrial flutter is often going in and surgically just burning that area out with a cryo burn, like liquid nitrogen or something like that, and just burn that area out of it. If it actually went necrotic on you, you'd probably have the atrial flutter go away as well. You can try medicating it as well, and they're usually with a relatively fast rhythm. These are relatively slow because this is 40, but they're usually with a faster rhythm. First degree heart blocks has to do with that PR interval, getting longer and longer and longer. And if it takes a lot longer, it may not depolarize the AV node all the time, and that becomes a second degree heart block at that point. And you're missing a beat when you should have one. When you start missing beats, your blood pressure goes down, could cause a lot more orthostatic hypotension, could cause syncope, those type of things, which can lead to falls, or the patient passing out. A Mobus type 1 is simply a widening of the PR interval. Mobus type 2, it gets so wide that the conduction from the P wave really doesn't trigger the AV node every so often, and you're missing a QRS where there should be one, and that would be a Mobus type 2 block, which is called a second degree block. Mobus type 1 is also called a second degree block, but if you see a Mobus type 1 and it keeps coming back, I would go ahead and exercise that patient. You really wouldn't have much problem with that. Mobus type 2, I would not be exercising them. And that's often really what the answer choices are getting to. Should I exercise the patient? Should I put them on hold? Or should I activate the emergency medical system? Those are the 3 basic, most common questions. They're not really going to ask you very often what the arrhythmia is, but they're going to ask you, when you see this, what would you do? And there's three definite things I could do. Hold them and document, because every time you hold a patient for medical reasons, you should document why you're doing it. Number two, activate the emergency medical system if you think it's going into an MI. Multifocal PVCs, really ventricular fibrillation is a very much all multifocal PVCs. So if you see a lot of different looking QRSs, they're starting to get there. If there's a sinus arrest with a pause like this, where there should be a QRS in there, but there isn't, their blood pressure is really going to drop in this area. That can cause orthostatic hypotension and syncope. So I really wouldn't want to exercise them. I wouldn't want to get them walking and have them pass out on me. I probably don't want to even get them in a chair and have them pass out in a chair, because if they pass out and slump over in the chair, you have a horrible time getting back to bed again without really stressing the daylights out of them. Like here, there should be a QRS in here, which is missing. That really would indicate a second-degree block. Since I have a P wave most of the time, it's sino-atrial. If I didn't have a P wave, then it would be, again, a second-degree block, but it would be an AV block and a missed complex for a Mobus type 2. There should be a complex there, which is missing. And these are, I didn't draw this too well, but these are getting wider and wider and wider. And yeah, it does sort of indicate that, but there should be another complex here, which is missing. A lot of the secondary blocks are affecting that AV node, the bundle of His, and the bundle branches. They tend to be relatively fast. These are definitely a tachycardic type thing. There could be P waves, but they're being sort of absorbed by the QRSs, so I can't tell. I know it's ventricular tachycardia because the ventricles are depolarizing, and they're depolarizing fairly regularly, but really, really fast. Bundle branch blocks, you have right and left bundle branch blocks. In a right bundle branch or a left bundle branch block, the right bundle will fire before the left fires because it's being delayed. You'll have two peaks of the R wave. Right bundle branch block, you just have a widened QRS. So the Q to S would be over 2 boxes or over 2 millimeters. You wouldn't want to exercise somebody like that, because when that gets wider, the force of contraction drops significantly. Wenke-Bach, again, you're missing the QRS. It should be QRS, but this came from England, so they use QES instead. And it's repeating. I wouldn't want to exercise somebody that's doing this because their blood pressure is low, their systolic pressure is particularly low, because the systolic pressure is related, it's a force generated by the left ventricle. Pacemakers are put in the left side. There's a battery pack, and then you feed in to the subclavian vein, the electrode, and that's going to terminate right about where the AV node is. And what you'd see on EKG is a straight up and down line. You see this little thing before the QRS? A more straight up and down line, that's the pacemaker firing. And then you get a QRS behind it. A 1-to-1 means every time the pacemaker fires, the AV node is stimulated, which is normal functioning of a pacemaker, if their heart rate's low enough. And pacemakers are usually demand pacemakers, so they're set at like 70. If the heart rate goes below 70, it'll turn the pacemaker on to try to stimulate the heart. As I said, most of the time, this happens when a patient's sleeping at night more than anything else, but it could happen during the day too, but oftentimes you see it more at night. Sometimes you may see a couple pacemaker spikes before you get a QRS. That's a good sign the pacemaker battery is starting to wear out, because it's taking a couple impulses to really capture the AV node, maybe 2 or 3 pulses before the AV node is captured, and you get a depolarization of the ventricles. Those, particularly the precordial leads, are often one of the easier ones to use to identify where the MI is, but that's related to the heart being normally placed in the chest. And I've had patients where the heart's on the right side instead of the left side, and sometimes it's not twisted the way it normally should be, or it's not angled the way it normally should be. So there's a lot of variance from one patient to another, which makes the idea of axis fairly inaccurate. We now have heart scans where they would pump a patient up with a certain radioactive tracer that would identify the area of the heart that's ischemic or the area of the heart that's necrotic, and they basically roll them through a CAT scan, and you can see it in 3 dimensions. So you can see the portion of the myocardium that's having the problem and the amount, and you can actually measure it very precisely with that. And it doesn't really care how the heart's being placed in the chest. So it's more accurate. Coronary arteries on the exam, I would say the left descending artery, or LDA or LAD. I've seen it both ways in reference sources. That supplies primarily the left ventricle. And needless to say, that's the most important to our pumping. We want the left ventricle to have good perfusion to it. The RCA supplies more the area of the AV septum, and in that area, so you see a lot of arrhythmias when you see the right coronary artery affected. I think those 2 are most likely to be showing up on the exam. Oftentimes, the precordial leads are used to identify these to some extent. Again, heart scans would be the secondary test you would do to really define it better, but you would see things off of the EKG by itself by just comparing the different precordial leads and trying to locate the problem. But that's based on the heart being absolutely normally placed in the chest, which may not be the case. This is a left bundle branch block where I have 2 R waves. I got an R and an R prime. The R prime is a left ventricle firing, but it's delayed. So the right ventricle fired first. The right ventricle is much smaller, so you don't have nearly the amplitude that you would on the left. I also have a depressed ST segment here, so slightly below the isoelectric line, the J point would be. So they'd probably have myocardial ischemia, which would give them some chest pain. Actually, if I look at some of these leads, it looks like this patient also has atrial fib going on as well. But the inverted T wave or a depressed ST segment would indicate an MI. Activate the emergency medical system when you see something like that. And you look at, I usually look at V5, yeah, going down slightly. Lead 1 and V5 are probably the 2 that you're going to pick it off the most. Left ventricular hypertrophy is a really common problem because when the heart muscle heals, it fills in with scar tissue, and the heart is beating as it's filling in. So the scar tissue ends up being elongated. Now the scar tissue itself doesn't contract, so it allows the ventricle to get larger, but not necessarily have the force of contraction to it. So it doesn't really empty fully. Again, that would increase your risk of stroke. So it's fairly important to pick up on this. Very common in geriatric patients. V1, you see really a downward projection of the complex because it's looking from the atria down through the heart. So the depolarization is in the opposite direction. That inverts the QRS. So V1 usually has an inverted QRS. So does V2. V5 usually has the upright QRS, and that reflects best my pumping capacity of the heart, because the left ventricle is most of the pumping capacity. But the distance here, if I draw a line here down and get that little distance between the S and the Q, it should be less than 2 boxes. Hypokalemia, you sometimes see that a lot wider, and that means a lot of accommodation is occurring within the myocardium, which means it's not producing a ton of force. You usually see symptoms fairly similar to an acute onset of heart failure as a result, particularly left-sided heart failure. You can also have right ventricular hypertrophy if your MI was on the right side of the heart. Again, you see a widening the Q to the S again. You may on the PT exam have one question dealing with the QRS. You may have another one, a bigeminy or a couplet may be a possible on the exam, a bigeminy, but you're likely to have an arrhythmia that you need to change what you're going to do, or you may just do what you're planning to do. If they have atrial fib, I'm just going to go ahead and do what I was planning to do anyway. If it's undiagnosed, I want to make sure their physician knows about it because there's a high risk of stroke. But exercise itself would decrease that risk while I'm working with them. So, and not necessarily increase the risk afterwards. So there's no reason not to exercise a patient like that. Matter of fact, you're decreasing the risk when you are exercising them, although you can't constantly be exercising somebody. But there's a high correlation, 80% increase in the risk of stroke with atrial fib, or atrial flutter for that matter too. Did that help? And you can open the chat or open the question panel. Did this sort of simplify it for you? Thank you. it makes it a little simpler to look at it. Definitely that ST segment, if you have two questions, one's going to be about the ST segment. I can almost guarantee you that if you have two strips on the exam. If you have one, it's probably going to be ST. If you have two questions, it's going to be one of the other problems we had. I would say left and right ventricular hypertrophy, that's more of a cardiac specialist exam question. So that's taking it up one level. And if you really want to get into this, there's the cardiopulmonary specialist exam you can take through APTA and be certified. You have to recertify every 5 years by retaking the exam again. You also have to have proof that you're working with cardiac patients, and there's so many hours you have to have devoted to working with cardiac patients to be allowed to take that and sit for that exam. It's a separate exam. It's really not well. APTA certifies it, but really other agencies don't. So yeah, it's sort of nice to have, but it's not going to increase your salary at all. There's also certification through American College of Sports Medicine, which is more recognized because it's an interdisciplinary organization where you have nurses, you have cardiologists, you have physical therapists, you have exercise physiologists involved with it. And they take an exam and they can be certified as an exercise technician. That's sort of the entry-level thing. It's a very technical test, a lot of strips on it. Then you have a program director, which actually takes a PhD to be able to sit for the program director one. And yes, I am a program director. And I used to be a paramedic, so I've done it. Any more questions? I have the question box open, so if you want to type something in, do that. Otherwise, I'm pretty much done for the night. Good. The EKG is a confidence building thing. Two questions, probably not going to affect your total score on the exam very significantly. But if they bug you, it'll make you probably blow 3 or 4 other questions that you normally would have gotten because you're getting frustrated. So this here, as an entry-level therapist, we really only see a patient on EKG when we're in the ICU or the CCU. You rarely would see them other than that. Okay, have a good night. You're welcome. Tomorrow night is going to be safety, the webinar for tomorrow night, which is something that'll show up both on PT and PTA exams, more having to do with IV lines, how to deal with them, how to deal with a central line in the patient, AV shunts that you use for dialysis and other reasons, HEP locks, catheters, Foley bags, and chest tubes. So it's a lot of patient handling stuff that you really do need to know how to deal with, because a lot of its positioning is important. A lot of it is where you place the things. It's stuff that when you're working in an acute hospital, you basically confound you every day. If you're working in outpatient ortho, you never see that stuff usually. But if you're in the acute hospital, you're in like a skilled care nursing facility, those type of things, you have to deal with it and know how to deal with it properly. We'll probably talk a little bit about grounding and use of extension cords and things like that as well, which is usually a no-no, using an extension cord. If you're around water, you need a ground fault interrupter circuit, which is like a circuit breaker that will snap the power off really quickly so you don't end up electrocuting the patient. And every time you have water close to electricity, you should have a ground fault interrupter there. So things like that will be tomorrow's webinar. There'll be a lot on patient handling. And maybe we'll talk a little bit about positioning too, because really sometimes the answer choices are different positions, and it's why you would put them in a certain position. And I can't see any recent reference sources that really do a good job of explaining that. But the exam has a tendency to hit it fairly hard. Like we're talking maybe 5 questions or 10 questions on the exam. That can definitely make the difference between passing and not passing. So tomorrow night's lecture is important to both PTs and PTAs. And PTAs may be even more important than PTs, because PTAs are usually working in inpatient facilities where the patients have these things. PTs, a good portion of them work in outpatient where you don't even have to deal with it. And you never know where you're going to be practicing 5 years from now. So, or what's coming down the board. They're trying to put every patient possible going from the hospital to home health to outpatient. You're trying to always get them into outpatient. So we're starting to see more pathologies than straight orthopedics in an outpatient setting. And facilities are trying to have patients in there all day long. Ortho patients usually come in before work and after work, maybe over lunch. Stroke patients can usually come in any time of the day, or other problems like amputees or something like that for gait training. That can come in any time during the day, usually because they're usually not working during the rehab period. So clinics, if they're smart, they start marketing to that to fill the clinic up during the day. Otherwise, you might want to work from 6 a.m. till 9 a.m., close your doors, reopen your doors at about 3:30 to 5 o'clock, and then go to about maybe 11 o'clock at night for your outpatients, for your ortho outpatients, because people are coming in after work and things like that. They're coming before work or after work usually. During the middle of the day, you can sort of shoot a cannon through most orthopedic clinics and not worry about hitting anybody. Okay, talk to you tomorrow night. If not, I'll talk to you on Saturday night. Next week, I'm going to, when I set them up and give you an email, I'm going to give you the emails or the logins for all the webinars throughout the whole week. And my other instructor, Mary Lou, is going to do some of the administrative topics, because she's actually a lawyer that goes in and defends PTs when they get in trouble. So she's going to hit sort of the legal end of it a lot, and that'll be probably Tuesday of next week. I need to talk to her and make sure which day she wants to do it on, but I know she could do it Tuesday or she could do it Friday, or maybe even Monday. So I haven't put that together yet. I'll probably put that together on not Friday, but Saturday or Sunday. I'll email it to you. And since I've been sick so much, I'm just going to open the webinars up to everybody and give you the full 9 weeks of webinars, because having too many people in a webinar, no problem. Bye-bye.